Thank you everyone for joining us again for the first webinar here in 2019. We are very excited to have Zach Willette from Ascension joining us today. And I always mispronounce the name of the organization you're representing, so say it for me.
Yeah, Allay.
Allay. Okay, I want to say like Ally and Allay, and I know I'm going to butcher it, so Allay. Zach is joining us from Ascension and Allay Care Services. Zach is also involved in the Chaplaincy Innovation Lab as well. One of our project leaders. He does. He just contributes so much to us in terms of thought leadership. So we're so excited to have not only his participation in the lab, but his time here today. So Zach, I will let you take it from here because I know you have quite a bit to tell us about LA.
Yeah. Well, good afternoon or good morning, everyone. It's a pleasure to be with you. I was telling Michael that at Ascension, we have a tradition of beginning every meeting with a reflection. And it can be, sometimes it's a prayer, sometimes it's a poem, sometimes it's an image and just some silence. I thought because Mary Oliver passed away just recently, it might be great to just start with some of her words. I've yet to meet a chaplain who doesn't at least tolerate Mary Oliver, if not outright like adore her. And I was sharing with Michael that I had the privilege of meeting her a couple of years ago, and it was a momentous occasion for me. Okay, so let's just kind of settle ourselves in. And here are some words from the late Mary Oliver. When death comes, like the hungry bear in autumn, when death comes and takes all of the bright coins from his purse to buy me and snaps the purse shut, when death comes like the measles pox, when death comes like an iceberg between the shoulder blades, I want to step through the door full of curiosity, wondering, what is it like? What is it going to be like, that cottage of darkness? When it is over, I want to say, all my life, I was a bride married to amazement. I was the bridegroom taking the world into my arms. When it's over, I don't want to wonder if I've made of my life something particular and real. I don't want to find myself sighing and frightened or full of argument. I don't want to end up simply having visited this world. I believe this is from her book, New and Selected Poems, published in 1992. It's called When Death Comes. As chaplains, we are there when people find themselves sighing or frightened or full of argument, or we are there when they find themselves, as I believe Mary must have been, in amazement, ready to step through the door of curiosity. So sort of a quick overview of what I thought would be good for us to spend our time with today. Big part of it is going to be questions and answers at the end. But yeah, why innovate end of life? Why is it end of life that we innovated? What makes Allay unique besides our challenging to pronounce name? Which, by the way, we are adding this week a little pronunciation guide to our website. We debated 117 alternative names have been considered. But this is the one we're sticking with for reasons we can go to if you're curious at the Q&A. What do our services cost? I.e., how do we generate revenue? As you saw on the descriptor, we are a not-for-profit, but we are a revenue generating entity for our not-for-profit. So that's a big reason why we exist. So I was going into it just a little bit. How might you innovate? I recognize that you didn't just come onto this call to hear about the innovation that we're doing, but perhaps you've got some ideas for yourself. So I've got a couple lessons learned to share. And then some time for Q&A. And Michael tells me you can type in the questions at any time. It might be mildly distracting to me, but I'll persevere, and he will coordinate them and share them. He said also he'll interrupt me if there's any time I need to be interrupted.
Well, and you don't need to be interrupted now, but I'm going to do so anyway. And that is the fact that I don't want us to look at your point number 3 here, what our services cost and how we generate revenue. I really don't want that to be kind of like a negative part of our conversation, because I think this is something that every chaplain has to be aware of, no matter what setting they find themselves in, because these services, they represent a cost to somebody, whether it is an end client, like with LA, if it's a system, if it's an employer, they represent a cost somewhere. And even though so much of what chaplains do is really so emotive and interpersonal, it comes at a cost. And if we don't get a grip on that resource question, chaplaincy is not sustainable in the long run. So I just want to set the stage that way, and I'll get out of your way.
Yeah, I mean, as long as we're on that, I don't have this later, so I'll say it now. So in my role before this role, innovating by starting Allay, I oversaw spiritual care for all of Ascension. And one of the things that I was aware of was that because Ascension is a Catholic health system, or a nonprofit healthcare system that draws on the Catholic traditions, we have absolutely a floor for spiritual care. We will never go below this because we're so committed. It's so integral to our mission. But because, as Michael is saying, chaplaincy is not a revenue generating part of the hospital, there's also a bit of a ceiling. We can't really go beyond that. And so this effort is a little bit of a way to break through that ceiling and say, if you decision makers in healthcare can see that spiritual care is not just a cost center, but actually can be a revenue center, even if we're not yet budget neutral, right? Paying for ourselves or generating revenue, as Allay will be. Even if we're not yet there, at least if we can sort of move towards neutral, we've given ourselves a little bit of space. And I think that space allows some creativity, and it allows us to do what we know needs to be done. So yeah, thanks for that little soapbox moment here. Should we dive back in? All right. So why end of life? Sorry, I realized I have a slide before that. My slides aren't advancing always. There we go. I just wanted to sort of clarify the relationship between Ascension and Allay. So as you know, Ascension is this large, we're the largest not-for-profit. We operate in 24 different states, about 150,000 associates, 2,400 or so sites of care. Maybe it's more than that, sorry if I have my statistics right. And Allay Care Services is an innovation project powered by Ascension. It was designed by an Ascension chaplain, me, to fulfill Ascension's mission and expand Ascension's impact, while at the same time generating new revenue in the process. So all Allay associates, right now there's just me, are Ascension associates, and all of Allay's revenue is Ascension's revenue. But just to kind of put a sharp point on how innovation goes, if Allay fails to generate revenue, we will close up shop. So just a little grounding in the reality of high stakes is a phrase I use every now and then. But let's go back and see, where did this whole notion come from? Why are we innovating at end of life? And so I have a story that I don't have enough screens to pull up. So give me one moment. Sorry about that. I thought I had that worked out. But yeah, this will tell you a little bit about sort of why it is that we chose this particular way of being. Interesting. The document I'm looking for is not where I thought it was. Thanks for bearing with us, folks.
Technology always works until it actually has to, and then it doesn't.
Mm-hmm. It's true. Let me try one other way.
While Zach is looking, I'll just reiterate that we typically wait until the end to do any sort of Q&A, but if you want to type your questions into the box, you can do it now. It'll store them all. It'll keep them out. So if something comes to mind you don't want to forget, just put it in there, and we'll keep it in there, and we'll get to it at the end.
All right. Thanks for your patience. I found the document that I needed to have. We just moved offices and my printer doesn't work. So normally I have this story on a piece of paper. We're gonna have it on a screen instead. But yeah, this is the story, the sort of why we're innovating at the end of life. It comes from when I was a full-time chaplain at Rush University Medical Center in Chicago, Illinois. Both rooms that night were on the same ICU. In one, the family's exhaustion was a heavy cloak they couldn't take off. It made their movements slow and their anger quick. They wanted to do the right thing, and so did the frustrated doctors and frazzled nurses. But no one knew what the right thing was. The patient had never said anything about his wishes or even what made his life meaningful in the first place. The same kind of ventilator rattled in the second room, but was outdone by some Sam Cooke albums on repeat. This family had the same sadness as the first room, but right next to their heavy exhaustion was a quiet kind of joy. She said this time would come, they told me. She told us what to do, and she told us why we had to do it. I'm gonna miss her with every bone in my body, but we're gonna send her on wrapped in love. Both patients died that night, well loved and well cared for. You know, as chaplains, that I had the privilege of holding hands in both rooms, hearing stories in both rooms, handing out Kleenex and terrible hospital coffee and cups of cold water in both rooms. We signed the same paperwork and discussed the same practicalities. But I noticed that the walk to the elevator was not the same for these two families. Did we do the right thing? Was etched on the face of the first family. They knew there were more tough decisions to come. The second family had different questions. What do we do with her tomato plants? That's basically the only thing she didn't tell us. One of the hardest things that I saw when I was a full-time chaplain was also one of the most preventable. Families racked with guilt because they didn't know what to do for someone who suddenly, or sometimes not so suddenly, couldn't speak for themselves. We launched Allay to prevent that. We listened to people, young, healthy, old, sick, or anywhere in between. And we helped them name not just their wishes, medical wishes, logistical wishes, personal wishes, but also the values behind those wishes. Because sometimes wishes can't be honored, but values always can. The people that we've served so far tell us it is making a difference for them and for their loved ones. It turns out that even just talking about the reality of our someday death helps us to live this day more alive, more present, and more at peace. So that's the long and the short of why. And now I have to change screens again to this one. Let's see if I can make this work. Thanks for bearing with me. There we go. Slideshow. Great, so now you're able to see that. So you might be able to tell from that story that Allay is both the head and the heart. We really believe in combining all of these things. And that's not the only both and that we endorse. We're interested in what someone's wishes are and what's the why behind those wishes. We're interested in the person, the person who we're serving, the person who is helping us name, we are helping them name their wishes for end of life and for their care after they've died, but also for their people. We don't believe in just treating people in isolation, but really let's look at the bigger picture, the system that they're in. Again, this comes from our work as chaplains. We're interested in the living that happens at the end of life, as well as the details that begin with death. I'm on a one-person campaign so far to start a new 3-letter acronym of DBD, details that begin with death. So far, it's going very slowly. And then we're also interested in the way we plan stuff and the way that it actually happens. As chaplains, you know, it doesn't always happen the way we think it's going to. And that's one more reason why it's so important to know the why. I'd like to clarify right from the beginning, there are some things that Allay's services don't cover. So we don't cover wills, we don't cover financial planning, we don't cover estates or heirlooms, but we absolutely ask people if they have covered those things on their own. And if not, we encourage them without any particular, we'll make referrals or recommendations, but we say that's really important. We've seen how having those things taken care of can really reduce stress for your loved ones at this time of your life. These next statistics you for sure have seen before. 90% of people say that talking with their loved ones about end-of-life care is important. This is from the Conversation Project in 2013. 27% have actually done so. 82% of people say it's important to put their wishes in writing. 23 have actually done so. This is from the California Health Foundation, 2012. So what Allay does is we give people the opportunity and the ability to have these conversations. Because it turns out that just having the opportunity is not enough. Just having the ability is not enough. We've heard from a lot of our clients who are like, I tried to have this conversation, it just didn't go anywhere, or it fell apart because of X, Y, or Z reason. So that's why these are facilitated conversations. A board certified chaplain or a licensed social worker is the person who's going to facilitate your conversation to give you both the opportunity and the ability. We know that when we know what people want personally and medically at the end of life, 2 really important evidence-based goals can be accomplished. And these 2 aren't always combined, and we think it's worth noting them for that reason. The first is to reduce human suffering and anxiety, both for the client and for their loved ones. And the second, and this is what tends to get the attention of healthcare systems, is to sort of right-size the end-of-life costs. Most people, not everybody, but most people want less aggressive care than they end up getting. Some people want the aggressive care, some people want more aggressive care. But in the aggregate, enough people want less care, less aggressive care, that it can lead to some really important savings, especially at end of life. So we also see that what we do is to help people see that death is not a medical event, but a natural part of life that can be discussed in a genuine and honest way. So we think about those 90% of people who say it's important to do this, but haven't yet, 68% of them haven't yet done it. We're interested in helping them, but we're actually interested in helping everybody. Name their values, name their wishes, and then have the conversation actually with their loved ones. So let me go into a little bit of what makes Allay unique. So our guided conversations that we facilitate and the process that we have, it's been developed from years of experience on the front line in hospital ICUs, trauma centers, and the ER, as well as palliative care, hospice, and grief support. Our facilitators are master's level educated board certified chaplains and licensed social workers at the top of their field, in my humble opinion. It's a little immodest to say that when you're one of the 2 facilitators, but that's what we're going for. And we help people articulate their own values, of course, never imposing our own. When I'm talking to chaplains, you know that already, but for everyone else, it's important for them to hear that. We are, as you know, expert at listening for, well, what's the question behind the question or the comment behind the comment? That's a little bit about our process and our facilitators. Let me give you some high level stuff. As I've said, we go kind of beyond just the medical to integrate the personal and logistical aspects so that we really have a holistic and interconnected conversation. Again, not just about how you want to live at the end of your life, but what happens after you die. Right now, our sort of continuity of care falls off a cliff the moment someone dies, and we don't think it has to be that way. Our process builds in time to reflect between conversations and prompts that reflection with custom education materials. And from the beginning, the client's wishes and preferences are documented in their own words to create a fully customized portfolio. We really think that using the actual person's words matter. We've had some of the children of some of our clients say, oh my gosh, I can totally hear mom. Like, that's exactly how mom talks. I love that you got the exact wording. Other important things, each client, and this is like maybe the first really radical idea, each client chooses family members or other loved ones, often their healthcare agent, to join the conversation, both to hear the decision straight from the horse's mouth, so to speak, and when applicable, to help them make that decision. Let me tell you, if nothing else is accomplished through Allay's work, we are radically increasing the number of really excellent healthcare agents. We've all been there in the hospital when the healthcare agent is like, I don't know, they never told me what they want, or I can't think in this moment because I didn't think this was going to happen. And with Allay, with this process, the healthcare agent was like, well, I was there when mom said she wanted this, or I was there when dad and I decided that the best thing for him was going to be X, Y, or Z. Travel is not an issue, as all conversations can be done via phone or video conference, and everything happens at the client's preferred pace, whether it's complete in 2 weeks, 2 months, it could even be over 2 years. It's there, we put their volition really front and center. So what is the actual package? What is a person getting when they buy our services? They're getting 3 sessions that involve 3 hours of focused conversation and supportive educational materials that we don't overwhelm them with. We have a process for learning what they want to learn about, and then we give them that information when they request it. It ends up with a customized care decisions portfolio that's written in their own words, as well as all the official forms that their medical team will need. It's delivered digitally, so they can have it as a PDF and share it with whomever they want. And then we also deliver print ones on request. We've served a number of millennials who are like, oh my God, do not send me anything in the mail. I don't want any more stuff. And we've also served a lot of boomers who are like, you're going to give me like a hard copy, right? So it's really interesting to see the generational differences. I won't read these all to you, but I just want you to have a little flavor of what actually ends up in the care decisions portfolio. I got permission from these 3 people to share these little quotes of what their own words look like. You'll see that it kind of covers a lot of different bases. I do have a slide coming up of what we actually cover, so you can see that, but I'll just take a brief moment so you can read that. I mentioned millennials. Often when people think of end of life, they automatically think of people who are, a certain age or older. And that certain age is not a young number. It's usually like, well, once you're 70, you should be thinking about this. Well, we made a point of searching out in our pilot phase people who are in their 30s and providing the service to them when they agreed to. This next quote is from a woman named Lauren, who lives in Florida, who's age 31. She said, wow, this process really made a difference. Now I know what I want, and it's recorded, and she made a copy for everyone in her family. So let me just give you this highest level overview of our process, because I don't want to get too into the weeds here, but we start with a survey. It's online. It takes about less than 10 minutes for people, and that gives us a ton of data that we can start orienting the process already to that person. One of the fundamental questions, a lot of them are sort of multiple choice questions, but one of the most important is, how would you name 3 enduring values? And that process, that is really the launch pad for so much of our conversation. They're not locked into those 3. They can add more and be like, oh, I said this, but actually now I'm thinking more about this. But it's super helpful for us to have that from the very beginning, so people really feel heard and they see that their volition, their values is what's driving this whole process. Then we have what we cleverly call conversation 1. I'll give it, my next slide goes into a bit of detail on conversation 1. And then they get a roadmap. We're like, okay, we've had enough conversation to be like, this seems to be the direction you want to go. We have a check-in where they review some of the information that we've sent them. And then the big thing is really conversation 2. Again, very clever name. And that one is when they actually bring in their loved ones. I did one with a gentleman who lives in Tennessee. He had his spouse, his one child, adult child, who lived also in Tennessee, and another adult child who lived in Peru. And she was a part of the process. The distance didn't matter. That's sort of the joy of the technology available to us. All of that ends up with this comprehensive care decisions portfolio. So what do we cover in conversation 1? Here's a slide that gives you a high-level overview. We have 6 sections. The first is describing how you want to live at the end of your life. The second is naming someone to be your voice for healthcare if ever you can't be your own voice. That's classic healthcare agent. We always make people name 2 alternates as well, even though some states remarkably don't require that. And some states don't even have space on their form we kind of shoehorn it in. The third section is clarifying your views on treatments at the end of your life. And I'll pause here and say that what's, typical or conventional advanced care planning covers all of section 2 and some of section 3, but not all of what we cover in section 3. One good example is we ask people in section 3, what's your preferred balance between awareness and pain relief in your last days, as you imagine your last days? And it's interesting, nobody's neutral on that. Everybody's like, it's so important for me to know who's there. Or like, oh my gosh, I can't stand pain. I don't care if I'm asleep and I don't get a visitor. I don't know who's visiting me. I'm okay. It's really interesting. Section 4, 5, and 6 are sort of the details that begin with death. So deciding what to do with your body when you're done with it, guiding how your loved ones gather to remember you. Notice that it says guiding. We think that it's the dose that makes the poison. And we don't want to give people a chance to micromanage something that's really not for them. When you've died, your memorial service, if you choose to have one, whatever you call it, is really for the survivors. And part of that is for them to actually get to create it and be generative in their grief. And then 6 is settling important logistics for after you're gone. Those are the ones that require outside experts, like a financial planner, a lawyer, or a state agent. You'll see that typically what's covered in conventional pre-need funeral planning is all of section 4 and part of section 5. So this slide, more than anything, gives you a sense of how what we've innovated really is unique, that you can't really go anywhere else and get all of these things at once and get them facilitated by someone who's been through it a million times before, who's trained to listen, and to do this process with your loved ones being involved. So again, I won't read you all the slides. I'll just say there's some cool stuff here on the screen about what the Care Decisions Portfolio does. Can be updated anytime on their own. We give them instructions for how to update it on their own, or they're welcome to engage with us again to update it. Another person that we served in Tennessee said, hey, this was actually a really good exercise of communication with my spouse. He also said it's a relief making his wishes known. I'm looking at the time, and I don't want to go into too much detail, but we'll just highlight, I won't read the slide, but we designed this to bring about peace of mind, clarity, and confidence for both the patient and for their loved ones. And that, I think, is something unique, and it really grows out of our experience as chaplaincy. So pricing, none of this is free, so let's actually pause on that. So someone could go and get the advanced care planning stuff, the typical advanced care planning done for free. And there's lots of online resources where you could, on your own, go about and take care of these things and have the decisions documented. So what you're really buying when you're hiring Allay is that facilitation, as well as getting it all put into one place. So it's really these 3 hours of focused conversation with a professional. And so the price is higher than most people think it's going to be, or lower. We've heard a lot of people say it's lower than they think it should be. But most chaplains I've talked to are like, ooh, that's a pretty high price, $650. But think about it as 3 hours with a trained professional. If you had 3 hours with a lawyer, just the time alone would probably be more than that. And the document creation might be separate from that as well. Again, we're not lawyers, just so we're clear. I'm comparing myself to that service, but we don't pretend to be lawyers. And because we are so committed as an organization, Ascension is, to caring for those who live in poverty and caring for those who are vulnerable in other ways, we've created a number of ways to reduce those rates. So you can get a reduced rate through a chaplain referral within the Ascension system, referral from a financial planner. Those have been people who are very eager to have these conversations and help it happen. Employers, we've talked to a number of employers who are making this a benefit that they can offer to their people to say, hey, we care about you not just for the 40 hours you're with us, but we really care about you and your life and your loved ones. And we want to help you give peace of mind to your loved ones. First responders, teachers, veterans are groups that we're considering creating special discounts for. If you work for Ascension, I mentioned 150,000 folks do. They get a special discount. And then we have a special discount for hardship. And on all of these, it's sort of the honor system. We're not going to make you prove that you're a first responder. If you tell us you are, then you get that discount. It's available for gifting. This has actually been an innovation within the innovation, that some of our early adopters were people my age, I'm 45, buying it for their loved ones, for their aging parents, and giving it as a gift, which is, of course, a gift for the whole family. Importantly, I want to highlight, when someone does gift it, the gift recipient, so the person it's for, does not get an email about it. The email goes to the gift giver. So that, if I were to buy this for my parents, it comes to me, and then I print out the certificate and I talk to them about it. There's no random emails of congratulations, people who you love are thinking about how you're going to die one day. How do people sign up? It's all done online at allaycare.org. This has been another lovely innovation. The code that people can use for reduced rate gets entered right there. It's a seamless, easy system. If someone already has an appointment taken that's not available, that time isn't available, and they just can pick the times that work for them. All right, I'm gonna switch gears, and my screen and I are not agreeing. Just so you see that actually I'm a human being here talking. I'm gonna switch gears now and just do a couple slides on what innovation could be like for you guys. We're at the halfway mark. So I'll go into that, unless Michael, you wanna take some questions now?
Well, actually, I would like to ask a question, and I'm going to ask it because it gets asked of me a lot in some of the other settings that we work in, not just in healthcare. And I don't say we as in chaplains, but the Chaplaincy Innovation Lab. As you're going through that, you mentioned a couple of times that part of the reason that this is a useful thing to do is that you are trained to listen for the question behind the question, the comment behind the comment. So my question, and there's no question behind it, but
there always is, Michael.
My question is, why is it, how are chaplains uniquely positioned to help facilitate these conversations? That's a question that I get all the time, because people say it could be a social worker, it could be, a sort of a clergy person that's part of a congregation. So my chaplain's uniquely positioned to help do this.
Yeah, your video froze for a second, but you're back. So I heard the question. Yeah, a number of reasons. Because we say that death is not a medical event, even though it's treated in our system so clearly like a medical event. Chaplains are uniquely positioned to bridge the medical and the non-medical world. When you talk about a ventilator, when you talk about a PEG tube, we know what that is. And so we don't answer the questions on the level that a doctor would answer, but it's because you're thinking ahead. You're just not like, you need this right now, get an opinion from a chaplain. No, you're getting your opinion from the doctor. But the chaplain can help you understand that. But also that chaplains think holistically. Social workers do too, clergy people do too, but they don't have the particular training that we do to sort of bridge that world. That said, social workers do. And so that's why we made the decision to hire both board certified chaplains and social workers. But we're looking at social workers, especially who have that experience in the medical setting. We have a couple, the one consultant we've hired, I can't wait till we can hire her as an associate. Right now she's a consultant, did some great work with end of life care. So that's a long answer to a short question. And I could go longer if you wanted, but but let me keep going with the other slides here. I believe they are shared again. So if you wanted to innovate, this is my first ever startup. So I've learned some things the hard way, and I don't know everything. It's very important to acknowledge what you don't know. There are whole libraries that are full of things I don't know. But if you were asking me, how could you innovate? I would say, well, what problem are you trying to solve? That's the first thing you've got to get really clear on. And I have a slide, the next slide goes into a little more detail. Who else sees it as a problem and who doesn't? So, this partially came from my experience in that ICU, that night that I was the on-call chaplain, of seeing these striking differences in these two rooms. For some people, that's not a problem. That's just normal, right? So it's important to get a lay of the land of who are your allies and who just doesn't see it as an issue. Who else is trying to solve it? Don't spend too much time on here, because you can sort of endlessly talk yourself out by saying, well, everyone's trying to solve it. And I had to get coaching from, Ascension actually has a chief incubation officer named Jason Dinger, who's a brilliant human being. He's a great coach to me. I'm one of 11 different innovation projects that Ascension is incubating at the moment. And he often has reminded me that your innovation might be your approach, or it actually might just be that you bundled things together that didn't used to be bundled. Or it could be the pricing, how you price this could be the innovation, or it could be something else entirely. So don't be spooked when you find other folks are doing sort of similar things. You might find your innovation yet. And then this is a really important thing. Interview everyone you can about the problem. I think I did over at least 50, probably close to 100 interviews. Patients, doctors, social workers, people in the funeral industry, you name it. And it's really important that the conversation be about the problem. As soon as you start talking about your solution, they're like, well, what are you thinking of, Zach? And I'm like, well, here's this really great idea. At that point, actually, the most useful part of the conversation is over, because we need to really understand the problem we're trying to solve, not just pitch this really cool idea that we have. That's a major shift. More on that in the next point. And then get really honest about, could you do only this and all of this for much longer than you think it will take? I'm astonished. It's been almost a year since the beginnings of Allay were born, and I really thought it would not have taken this long to be where we're at now. I'm thrilled where we are, but I'm surprised how long it has taken. So let me dive into a little bit of that. These are some slides from a presentation I did for some students at Portland State University about making change in a large institution, or really anywhere, but they apply here as well. Don't fall in love with a solution. Fall in love with a problem. If you only get one thing from this webinar about innovation, let that be the thing. And this I learned directly from Jason Dinger. Falling in love with a solution means that you're a hammer and looking for a nail. But falling in love with a problem means the more you learn about how tricky it is, the more enamored you become. And that's going to serve you really well in innovation, because it turns out everything is trickier than you think. And by sticking with the problem, you're going to find other people who are also intrigued by that problem, which is way more useful than finding other people who are interested in your solution. Make sure that the problem you fall in love with is a problem that your organization, whatever that organization is, cares about, sees that it can change, and derives some benefit from solving. So it's not full-on Machiavellian, but you do have to keep in mind that people, resources are tight. And Michael already made a reference to that. People will not get on board if they don't see that there's some benefit that can come from actually solving the problem. Talk about the problem and the problems behind the problem. Again, use your chaplain super skills to look at the issue behind the issue. Fight the urge to pitch the solution. I learned it the hard way. I had interviews that were going great, learning tons of stuff. And then I started pitching my solution, and it was still a fun conversation. The person I was talking to was thrilled, but it stopped being useful to me because I wasn't learning about the problem. There's always more to learn about the problem. People will want to tell you their ideas about the solution that you have in mind. And unfortunately, you'll just get ungrounded data, what Jason calls well-meaning noise. So people have a good heart, and they're like, "Oh, I have an idea for your idea." And you're like, "Well, actually, the best thing you could do is tell me more about the nuances of the problem that I'm not seeing because of my blind spots." So talk to people about the problems that they're facing, and you get very grounded data. That's the difference. Stay rooted in the problem that you're solving during all the pivots, because there will be pivots. They will test your resolve as a change agent. But if you're in love with the problem, then those pivots will be mostly energizing. I'll admit there have been some pivots that have not been energizing for me. Okay, a couple more points. If you have it in your brain for 2 slides, the first one was to remember that fall in love with the problem, don't fall in love with the solution. And the second thing to remember is this: change is slow, except when it isn't. So I've given up predicting how long things will take. To operationalize, you have to sort of have a sense, but you have to hold it really lightly, because some things are slow and some things are not. let me give you a couple of heads up, and then we'll move into, I have a couple slides, and then we'll go into Q&A. It will be slow, I already said that, and not in the ways you expect. So some real humility is called for. I've learned that lesson daily, I think. Like, okay, I didn't see this coming, but I'm gonna roll with it. Innovation will require partners, and you don't always know which partner you need before you need them. So again, a little bit of humility of like, wow, hi, I should have called you 2 weeks ago, and I didn't know that I should have called you 2 weeks ago. Can we talk today? And discern, good chaplain word, that which you can surrender and that which you orient yourself to. Those are two really important things for you to be like, okay, I can surrender all these things. And okay, I want to be oriented towards this, because everything else is mud. It really is muddy. As a son of a farmer, I can tell you it's good, fertile mud, but it is messy. So in conclusion, going back to just a little kind of the lay stuff, many people aren't sure where to start conversations about end of life, or they're overwhelmed by these conversations, but they do want to have them. And what Allay does is we make that possible. So think, which ICU room would your patients want their family to be in? Before we go to Q&A, I get a lot of Q&As that I have learned to head off at the pass. By just giving you some FYIs. We are headquartered in Minneapolis, Minnesota, where yes, it is currently, let's see, current temperature is 18 degrees below zero. It's warmed up now that the sun is out. It is colder here than in Antarctica. I like to point out it is summer in Antarctica, however. Allay will be hiring board certified chaplains and licensed social workers locally here in Minneapolis, and ad hoc. We have a strong desire for Spanish speakers. Depending on demand, we might get to expand in 2020 or 2021 to wherever the demand is strongest, potentially officing where Ascension already has existing space. That's a good use of existing resources. And we want to expand because a small percentage of clients actually do prefer this process in person. The phone has some pros and cons, and in person has some pros and cons. So with that, I'll turn it over to Michael to see if there's any questions that have come in.
Yeah, so we do have a couple of questions that have come in, and all. The first question has to do with basically sort of the sources of payment for services like this. And someone asked, they say that I have heard that there is Medicare reimbursement for a qualified practitioner to do this work. And so I want to hear your answer, and then I want to follow that up with a little bit of research as well to talk about. So anyway, take that.
Yeah, Michael, your computer froze, at least it did on my side when we got to the actual question. So CMS does have this qualified professional. Yeah. And the particular nuance of the question was, now you froze again.
Yes, you're freezing for me as well. Maybe it's the ice outside that's getting between us.
Maybe, yeah.
Okay, so Medicare reimbursement, how does that work with Allay?
Oh, sure. So the Center for Medicaid, CMS, Center for Medicaid Service, has not ruled yet on who actually is a qualified professional. So we have not touched that with a 10-foot pole. Sure. Because it is, all of our compliance officers tell us that if the ruling comes out against us, it could technically be considered Medicare fraud, and no hospital ever wants that on their record. So we're being super, super cautious. I do know that different hospitals have had chaplains be a qualified professional and have successfully been paid. I know that my colleague from when I was in Rush, Aoife Lee at Rush Oak Park in Chicago, published a really great little research letter. Is that what it's called? Research letter in JAMA, which is outstanding. But yeah, that's if that does come, we would love to explore that. That said, what Medicare are paying for is just the medical slice. And so we would have to be really careful about being clear, saying, and now that is over, and now we're beginning a new conversation that we're not charging for. And that doesn't really appeal to us. We really like the holistic one conversation, because one of our operating theories is that only 30% of Americans have any sort of advanced directive, in part because it's all the thanatophobia and fear of death and death-denying culture, et cetera, et cetera. If you're going to push past all that discomfort to actually have the conversation, you don't want to have just part of the conversation. You
Right.
don't just want the medical slice. You want the whole enchilada.
And actually, just for the participants, I dropped into chat the link to Transforming Chaplaincy that talks about IFA's research letter, because this is actually a really important part of seeing how chaplains are integrated into the entire process. Now, I know that you're coming at this sort of from the other side of viewing this very holistically, but at the same time, I think it's important that we begin to understand chaplains as an even more integral part of the medical side of things as well. Really, you mentioned the phrase earlier of bridging that divide, and I think that's so important. But of course, we need to focus on really clearly seeing that chaplains do have a foot in both sides. It's not like one side or the other, but it's medical and everything else at the same time.
Yeah. Well, I mean, to go with the metaphor, a bridge is only reliable if it is solid on both sides.
Exactly. Right. Someone asks, how did you arrive at the name of Allay Care Service?
Yeah. Our first name was Spirar, S-P-I-R-A-R.
As a focus group of one, I will say I'm glad you didn't pick that.
Yeah. I mean, it's great, like etymologically. Like it's the root of the word spirituality. It's the word inspiration, expiration. Like it's an amazingly, in my humble opinion, great word. And it's terrible because people don't, because it's a new word. And then a lot of startups do they can make up a word, or they do a portmanteau where they put two words together.
Right.
So we tried that for like a nanosecond, and then we're like, no, people are stumbling over how to say it, which ironically still happens with Allay, but most people are familiar with the phrase allay your fears.
Yeah.
And etymologically, I don't have it in front of me. It'll be up on our website soon, but etymologically, it actually was related to letting go of a burden, like literally laying down a burden and letting go. And we see that so much of the death denying in North American culture is this like grasping and holding on and like, I'll live forever. And we encourage chaplains, we're always asking people to let go, and we have to let go of things ourselves. So that's part of where it came from. It also, our lawyers did the search, and there is a home hospice that uses the name, but what we do is different enough from them that we think we're going to be friendly with them and not competing with them. And so it was a word that was available. I literally had a list of 117 potential names, some of which I loved, but were already taken.
Yeah.
And so we ended up with Allay.
Another question, this is really interesting because just looking at the attendance list right now, I see so many names that I recognize from various healthcare chaplaincy settings. Cool. And someone asked, what does the sort of the relationship look like between you and Ascension? You're sort of at Ascension directly, I guess I would say, before, and now you're with this. So you mentioned a little bit about Ascension's incubation sort of mindset. How does that work?
Yeah, so like I mentioned, we're one of 11 incubatees. We're the only one so far that's coming out of spiritual care. And the reason is that's important for us to, as we were talking about at the very beginning, to show that spiritual care isn't just a cost center, that we bring something to the table, a lot of things to the table, including the capacity of generating revenue. Sometimes the way I explain it is that Ascension's about a $20 billion nonprofit, and about $4 billion of that, depending on your definition, is care for people who live in poverty or care for people who are undocumented or otherwise vulnerable. And we are looking at the next 5 and 10 years and recognizing that we will not need less care for people who live in poverty.
Right.
And so how can spiritual care, while still upholding our mission and expand our impact by generating new revenue to sort of help meet that? So yes, as I had that slide in the beginning, Allay is Ascension. In the Venn diagram, we're a tiny little, part of it. But yeah, all of our revenue directly goes to keep Ascension doing the good work that we're trying to do.
Sure. This is a really interesting question that I hadn't thought of before.
Yeah.
This question says, we deal frequently with unique cultures here in New Mexico. Many have cultural and spiritual beliefs that make these kinds of conversations more difficult to have. The level of avoidance when it comes to death makes it very challenging to engage in these future-oriented or present-oriented, if they're right at that stage, conversations and decision-making processes. So how have you dealt with that kind of diversity of approaches to death?
Yeah, this is great. So we're actually doing research right now into whether or not the language that we have on our website and in our process is as culturally competent as we think it is. Because that's not something you can have hubris about. You've got to be humble and sort of like learn if it is or if it isn't. But what I'll say is two really important things about our process. It is centered on the volition of the person. We use the term principle for the person that we're serving. And it includes their loved ones, whoever they decide as their loved ones. So for example, I live in Minneapolis. We have a very large, robust community here of immigrants from Somalia. And decisions, I'm speaking the aggregate here, so using some generalizations, but in general, medical decisions are made by elders. So if I have a medical situation, I won't make it myself. I'll have an elder make it either in consultation with me or I'll just defer. This process 100% works for that because the person's volition is like, I want that decision to be made by this trusted person in my community. And so the fact that we don't say, oh, no, what do you want? Like, you just told us what you want. And guess what? We're going to have conversation too, where you get to bring whoever you want to the table. And so there's a lot of, we believe, we hope, we intend to have a lot of respect for the cultural diversity that's present in our world today. Now, that said, I also heard a little bit in that question of cultures that are just have a cultural prohibition against talking about death. And that is a particular challenge. Those people probably wouldn't come into our door.
Sure.
But if they did, we would hope that our culturally competent programs or effort would be useful.
Sure. Now, this next question, I am not familiar with the content of it, so I'm just going to ask it and sort of let you take it away. I think I know what they're asking, but in any case, this person says, how are your services different from the Honoring Choices project here in Minnesota? Now, what I would say that question is about is, how is this different from, just advanced directives in general?
Yeah, great choice. I love Honoring Choices. I am so proud to be a Minnesotan because having looked at a lot of different state forms, Honoring Choices is one of the best out there, actually. And I like that our state legislature here in Minnesota has deferred to Honoring Choices in a number of ways. Not always, but there's been a great potential for partnership there. So what's different is that Honoring Choices is not by its nature a facilitated process, whereas ours is, and it's facilitated by a chaplain or by a social worker from beginning to end. So you can absolutely, sometimes Honoring Choices has been facilitated for someone, but it's also available to be used individually, just filling it out on your own. And if we think back of that, and I can pull it up if you'd like me to, but that slide of the 6 different sections, Honoring Choices makes a little bit of space available for, hey, if you have particular wishes for the care of your body after your death, put them here. If you have particular instructions for memorial service, there's a little space for that, or you can always, of course, attach more pages. But Honoring Choices does not get into the specifics that we do about, for example, who has the passwords for all of your online accounts that need to be wound down. Don't give them to Allay. Just tell Allay, so it can be in your document, who has them. And Allay, by the way, is going to remind you to update them. I'm telling people to update them on Groundhog's Day, because what else is there to do on Groundhog's Day? Update your passwords.
As we get to the end of time here, I want to be respectful of everyone's time, but
sure.
What really strikes me is that you had those couple of slides up earlier, and I'll remind everyone that we'll have those connected to the Allay section on the Chaplaincy Innovation Lab website. But this is useful for basically anyone, because you had those slides on how to innovate where you are. And I know that, especially for chaplains who are working in hospital settings or other sorts of healthcare settings, things are very often done in a very specific way. This is the system we have set up. This is the hierarchy. These are the methods. You show up for work and you do your job. And in a lot of ways, that's beneficial. There needs to be protocol. There needs to be a safe and effective way of just kind of operating without having to figure out what you're going to be doing every day. But I think that the pieces that you mentioned earlier on innovation and how to identify problems, what can be done about it, how to partner with people, I would really encourage everyone who's watching this to take a look at that and think very hard about that. Because, you know, all of us, we have various parts of our jobs or vocations, however you want to view it, where we see, you know, friction points, areas of tension. And very often it feels like this is just an intractable problem because this is how we do things and what can I do about it? But I think that what you have given us here on how to innovate, just to think in that kind of mindset has been really helpful. So thank you for that. I will give you the last word here and then we'll wrap up.
Sure, thanks. I was gonna expand on that. Chaplains we talk a lot about coping, right? We talk a lot about resilience. We help one of the ways I describe what chaplains do to people who don't understand is, say, we reorient people to their own resilience, right? Michael's making a really good point that too often as chaplains, because we think of ourselves as, you know, the forgotten stepchild in the healthcare setting, we have this narrative in our own head. We use our coping to just sort of suck it up and be like, well, this is just how it has to be. We're never going to get the positions we want. The research that we want to do to prove that we are necessary, that'll take 5 years. And we're probably going to lose all the funding we have in the meantime between now and when that 5 years is finally over. We can have a little bit of what in Minnesota we call a sort of winter fatalism, you know? And I think that doesn't serve us well as a profession. It doesn't help people take us seriously. It doesn't help people recognize the many gifts that we bring. And I think it doesn't help us take ourselves seriously. So we have a really unique perspective on what is broken in healthcare and how it can be fixed. I got into the position I'm in now because after 5 years in the emergency room of seeing how healthcare was broken, I needed to be part of the solution. I think of the trauma surgeons that I worked with at Cook County at Stroger in Chicago, who said, I can't just stitch people back up and send them back onto the streets. I need to be also out in the streets, helping do whatever I can do to prevent the violence that's getting them into my theater, my trauma bay in the first place. And I think chaplains, we have this similar opportunity. We see what's broken, and we are called in the spirit of justice to innovate and to advocate for things. Things are not yet. The world as it is not yet the world as it should be. Right. And we have a million big and small ways every day to make it more that way. And I think innovation is one of them.
Very good. Well, thank you for ending us on a very positive note. You know, an entire webinar built around preparing for the end of life can sort of seem a little dreary from one perspective. So I appreciate
people tell me, our clients are like, I didn't think I would be laughing during this conversation.
Yeah. Well, thank you for bringing us up here at the end. This has been really, really great. I'll just remind everyone this has been recorded, so we'll have it up on the website here pretty soon. As soon as we can get it processed, we'll have the slides up so you can take a look through those as well. And if you have any questions, get in touch with me. I'll pass it along to Zach. We would love to keep the conversation going. Thank everybody for coming. Zach, thank you so much for your time. This has been wonderful. It's always a pleasure to talk to you, and so I look forward to staying in touch.
That's a privilege. Thanks, everyone. Have a great rest of the day. Right. And if you're in a place where it's cold, stay warm.
All right. Thanks. Have a great afternoon, everyone. Bye-bye.